processing, NLP, and artificial intelligence to create production service that have improved the quality, efficacy of delivery of healthcare within Northwell. So he will talk to us today, again, another topic about AI, so applying AI in healthcare. Dr. Chung.
First of all, I'd really like to thank everyone, first of all, for staying, for ACAP, for the privilege of the podium. I know this is, can you hear me? Is it better? Okay. I know it's like 3 o'clock, and you know the good lunch is sort of setting in, so hopefully we'll try to get through this. So just before I go further, I am a general surgeon. I practice minimally invasive robotic surgery. That's one of the caps I wear. The other cap is sort of being an engineer in Northwell and creating, heading to different divisions of data science and also creating data science products within Northwell. And so today, I know I congratulate Lee for the fantastic presentation, and I wanted to just kind of shift gears a bit to talk about how to apply this, how to apply AI in healthcare, actually in practice as well. Let's just see. Right, okay, this one. So I have nothing to disclose. Again, this cannot and will not be a comprehensive survey of the topic, and these are all my own interpretations, and so take it with a grain of salt. And these are also my own opinions, and don't express the opinions of my employers. So today I'm going to just talk about a couple things. This question of what is AI. We use that word so much, so maybe we just take a step back and just think about it a little bit deeper first. What are the applications of AI in healthcare? And again, I'm following in the on the coattail. Let's give back to the expert. So again, what are the applications of AI in healthcare? And then finally, what are the challenges of AI in healthcare? Maybe this will kind of touch upon some of the very interesting discussion that we just had at the end of the last session. So artificial intelligence. How many people in this room are currently using on a daily basis some kind of product that uses AI, to their knowledge? And I think whether we realize it or not, everything that we use is using AI, from our Gmail inbox, or when we use Waze, everything, pretty much it permeates everything that we use, right? But what exactly is it? I like this definition. So this definition came from Encyclopedia Britannica. It says, artificial intelligence is the ability of a digital computer or computer-controlled robot to perform tasks commonly associated with intelligent beings. So that's like clear as mud, right? It really, no, it doesn't really tell us. It actually, I like this definition because it kind of brings home the point that no one really knows how to define artificial intelligence, because that requires us to be able to define clearly what intelligence means. The artificial part's easy. The intelligence part is the hard part. So, what I like about this definition, though, is that it kind of brings home a couple points. One is it has like this idea of this disembodied state of a digital computer. We can colloquially use words like models, to describe this. But also, we've also been talking about, I think inadvertently, things like robots, like a body version of AI. Things that we think about when we watch movies like The Terminator, things like that, right? And they seem to, in our common, in the common understanding, they seem to go interchangeably with each other. And I think that's one of the issues that causes a lot of this kind of confusion, because we have this idea that maybe is AI robotics, is it not robotics, is AI, is it knowledge? We saw from the last talk that, it encompasses a lot of different applications all the way down to describing genomes and interconnects in the brain of a fly. So what exactly is AI? Well, for the purpose of this talk, I want to think about two aspects of it. One is narrow AI versus general AI. And I would say that general AI is, I think, where we get really kind of caught up and confused, and no one has a really good idea of this. This is sort of the idea machine in the image of man, that there's going to be this new sentient race or this species or something that's going to come out that's going to have some kind of notion of intelligence and can do things, and maybe is going to interact with us and that type of idea. Or it's a whole spectrum as well, because it ranges to things like agents. Nowadays that term agents is being used a lot to describe different types of models or systems that can do some kind of intelligent behavior, and you can chain them together. But I think where we're seeing a lot of the application in healthcare, and speaking from my own personal work, this is where we're seeing a lot of the actual applications today. It's a narrow AI or task-specific type of AI. Things that we have algorithms that do a task that very well and with reasonable reliability, they're cost-effective, and they're going to be actually useful and helpful to clinicians like ourselves. So again, the question though is like why are we hearing so much about AI? Like why has it really come into sort of the common vocabulary? Like growing up, if you talk about AI, you were the nerdy kid in the class, and no one really took you seriously. If you read I, Robot, you were one of the kids who actually knew that this was an Asimov novel, and you were kind of that kid in the corner, right? But nowadays, everyone and their grandma knows about AI, speaks about AI. So what exactly happened? So this figure taken from Nature, I think it does kind of helps us to understand, because what it's showing is some of the task-specific benchmarks that occurred, and for a long time these were kind of novelties. I say novelties because human performance always vastly outstripped what algorithms could do. And then in about 2014 or 2017, this is when some of these algorithms really picked off. With image classification is really the first group of algorithms that really took off. Really 2014 is kind of the year, because that was AlexNet when that came out, and it was one of the times that these algorithms really did better than human performance. 2017 was already touched upon. That's when the Attention is All You Need paper came out. 2018 with OpenAI releasing GPT-1, and then Google releasing BERT, and the transformer models that have really dominated natural language processing. And so these tasks like reading comprehension, visual reasoning, language understanding, you can see that they really took off at about this time. Competition level mathematics, talking about nowadays these models can do better than almost middle level students. But this happened because of two things. One is that advances in particularly with deep learning. So these type of deep neural networks that came hand in hand with advances in hardware, with GPUs, with companies like NVIDIA providing processing power that enabled the training of all of this data that was kind of sitting there. So again, my focus right now, because we're talking about applications in healthcare, is really to focus on the narrow types of tasks. And this is not a comprehensive breakdown of what we might think, but we can think about it in terms of there's algorithm groups, and then different types of tasks. It's split into non-generative versus generative tasks. In the algorithm groups, we can think about things that have to do sort of with signal processing. Things like, we can think of images as being a two-dimensional signal. We can think of audio as maybe a one-dimensional signal. Video as sort of a multi-dimensional signal. Maybe if you're a cardiologist, thinking about EKGs, and or a neurologist, EEG. So these type of signal processing algorithms. So there's a group of that. The thing that I deal with a lot in my line of work is with natural language processing, dealing with text, which is still a kind of a signal. It's still a more of a discrete type of signal, but it's nonetheless a signal. And also nowadays we're talking a lot about multimodal models. Models, especially large language models, that can take both text as well as image inside, or they can take a video as input and spit out text, or vice versa. So this is a very interesting class of models that has really become mainstream really in the past year or so. And here, reinforcement learning is another interesting group of algorithms which deals more with not so much with the data, it deals more with the decisions. So given a set of policies or decisions, can the algorithm learn which decision is going to give you the best outcome? So this a great example of this is in March 2016. AlphaGo beat Lee Sedol and the best Go player at that point, and from that point on, these machine learning algorithms are doing better than Go players. So, but that was an example of reinforcement learning, and reinforcement learning also can apply to things like robotics, to decision making and all that. It's even being applied within large language models to do things like alignment, make sure that these large language models are saying things that are not, they're not spitting out curse words or obscene language when prompted by the human. But we can also, again, describe these things in terms of generative versus non-generative or discriminative tasks, like things that we kind of recognize like classification, segmentation, detection, and so on and so forth, versus generative tasks. So I think it's really been, I know this has been touched upon a lot, but since about November 2022 when ChatGPT was released, generative AI really came into the popular universe of our thoughts. But generative AI has been around for a very, very, very long time. It's just only been recently, though, that these algorithms have gone to the point where they've really impressed us in terms of their outputs and what they're capable of. So again, this is just one way to think about this. But as we look at this, the reason why I have this here is because in healthcare, especially when we think about applications, I like to think of these different groups, like these narrow AI groups, as being almost like Lego blocks. There are things that you can mix and match, and then depending on advances in one algorithm group or another, you can get the sum of the parts is more than each piece itself, sort of like what we see with Lego. And so, as we think about this, oops. Oh, interesting. I think I'm missing a lot of text here. Is there a way, maybe we'll have to switch over to the, I don't know what happened there.
I think what might be the case
is it just the text color?
Oh yeah, there's
color?
No, there's no text here.
There's no text. Oh,
no.
I sent over a PDF. Maybe we can
yes.
Switch to that. We had good enough AI, we predicted this. So clearly we're not there yet. Yeah.
Question.
Yes.
Can you use AI to prepare your talks and stuff? Does that help?
Well, yeah. So that's actually a big issue right now in education, right? Actually, especially with classes that rely on students producing essays, PowerPoints. It's all the rage right now to have ChatGPT do that for you, and it can do a pretty good job. And one of the issues that we have is that the algorithms to detect whether you're using an AI system or not, they don't work very well. So you have a lot of students who are, I think there was like last week or so, there was a story about some family that sued the school because the algorithm, whether the student actually used AI or not, I don't know, but they flagged it as being created by AI and suffered the consequences, so the family sued the school. So to answer your question, yes. This talk, I will say, was not made using AI. I swear. So yeah, we can think about these different types of use cases, detection, documentation, discussion, decision-making, doing. These are just, obviously not comprehensive. These are just the ways I think about it. But one of the things you might notice is that as we go down, we're increasingly touching upon algorithms or AI systems that have increasing levels of sophistication. And one of the things I like to talk about when I talk about AI, I like to think about them as systems because really, especially in healthcare, for them to be applicable, they have to be incorporated into some kind of data system or they have to work with your EMR. They have to actually be incorporated with everything. Otherwise, if it's just isolated by itself and it takes just as much work to get the data in and then to get the data out, they're not useful to us, right? So the first thing I like to think about is, so I'm gonna have to, I guess, ask you now if you go to the next one.
We try again?
Let's try again.
Yeah.
Okay, got it, okay. So detection. So this is, I think about detection as being something like, finding the patient's past or current state, and This is probably where we're seeing a lot of very mature products that are being used. I know in my healthcare system, we're using some of these products. I may be using your healthcare system as well. But things like a model that can look straight at the DICOM images and determine whether there's a lesion or whether there's a brain bleed or an aneurysm. Look at whether there's a C-spine injury, look at whether or not there's a chest lesion such as a pulmonary embolism or effusion, things like that. And even before the radiologist has had a chance to read it, flags it and puts it on top of the the pile so it gets preferential. In fact, even before the radiologist looks at the whole patient, the patient has been flagged to accelerate care being given so that care delivery is expedited and not delayed as we usually see at like 2 in the morning, right? So this is an example of a product that has received FDA approval. They're going towards getting approval for detecting lesions inside the abdomen. We've already seen how it can be useful in pathology. The thing I like to think about though is that, how are these systems useful? They're useful because they're relying on those discrete, narrow AI algorithms to do certain things like detection of lesions. So this could be either a segmentation or this could be a classification or a combination of them. We think of the same thing with pathology slides. Segmenting, you have a slide, you have millions and millions of pixels, and you can identify the exact range of pixels that maybe should be seen by a pathologist and undergo greater scrutiny as opposed to the others. In the surgical sphere, we're seeing this a lot more with video data, intraoperative data with different use cases such as same idea here, anatomic segmentation, identifying anatomy. If I'm doing gallbladder surgery, I need to clip the cystic duct and artery. I really don't want to clip this the common bile duct. I really don't want to go there. So, being able to not only detect what organ is it that we were grabbing, what instrument is being used in this situation, where are we? I know it's a little cut off, but this would say here, you're too low. You're probably too close to the common bile duct here. So, and then you can think about like Lego blocks. Like you can have, if you have these data input streams, and you can build upon it, and then you can even have assessment of trainees. Are they doing the right things at this stage of the procedure? Can we segment even the videos themselves into the part of the case? Are we doing the dissection? Are we dissecting the peritoneum right now? Are we in the portion where we're trying to obtain the critical view of safety? So that type of thing here, and even being used for the assessment of trainees or surgeons themselves. So again, this is what can be used in what we think about with detection. And again, use cases where especially image algorithms are doing very, very well, and they're very mature, and they're being used right now as we speak. Documentation, maybe this hits home very close to home to a lot of us, right? Because how many of us, I'll take a raise of hands. How many people think they spend way too much time documenting? Right? Yeah, so, this is the bane of our existence, right? And we've tried to use different types of tools like, dictation systems, many of which are actually utilizing AI to do transition from audio to text. So that actually is an example of AI. Dragon has been around since forever, and they were using those older systems long time ago as well. But nowadays, there's this idea, maybe we've heard of that term ambient AI or ambient technology, this idea that, there's going to be something in the room like, we kind of have this at home, right? We have like Siri or I forget what, Alexa or whatever they're called right now, and you're supposed to say something to it and it responds to you. So this idea that, well, what if every office had the same thing? There's a machine connected to an algorithm, and it's going to listen as I discuss care with the patients. And not only is it going to transcribe what's happening, but nowadays, we've seen that with ChatGPT and all of the other large language models. They do a very good job of spitting out coherent, fluent English, not just English anymore, multilingual models that can write in Chinese, in Korean, whatever. So even have it in your own language, have it in the appropriate format that the electronic medical record would expect, and have even a synopsis. There's even the idea of having feedback, that as I'm speaking to the patient, how often we've been in a situation, I'm speaking to the patient, and oh man, I forgot to ask if they had a colonoscopy or something like that, right? But something like this would kind of detect, hey, we're on this track, this patient's coming, you're talking about, clearly you must have some kind of notion that there's a colorectal cancer risk, like you probably should ask that whether they've had a colonoscopy recently. So, not just being a recipient, but also kind of helping nudge us in the right direction. So that's one idea of how AI can be used in documentation. And again, building upon the idea that this is building upon narrow AI. This is different use case, different algorithms that can be compounded upon each other to have something that's more than the sum of its part. There's systems that are working in some hospitals in the OR, and they are also like a black box type of system, which is trying to determine if it's recording what's going on in the operating room, can it detect when something maybe is going awry, or as in retrospect, like for a root cause analysis, to determine, was there something that happened that maybe we can point to so that it can help us improve the quality down the road. And I know this sounds, actually as a surgeon, when I think about it, it sounds kind of frightening, right? Because now we're touching upon some of the other aspects of AI, like medical legal, does this increase my medical legal risk? Or things like that. So one of the ways they've also tried to use AI here is again, detection, detecting people's faces and then masking them to preserve privacy, garbling up the audio, things like that. So they're also using AI, kind of ironically, to be on one hand a big brother, but on the other hand to try to preserve privacy, and both are AI, which is I think one of those interesting notions that's occurring nowadays. But again, this is actually being used, at least in some of our hospitals in Northwell, and I'm sure in many other hospitals across the country right now. But this is again another instance of how AI can help with documentation. And I didn't put a picture here, but as a surgeon, even thinking about taking the video and converting it directly into, let's say, a transcription, an operative transcription or procedural transcription. So that's another use case. So also discussion. So, this is very closely related to documentation, but we can think about it as being more having to do with communication. Communicating to maybe other care providers, but also communicating to patients themselves. Oftentimes that aspect of medicine is really overlooked simply because we just don't have the time and the effort to put effort in there. Also, when we think about communication, education is a part of it, right? Like communicating with students and trainees and making sure they take away the correct thing. So, this is where we're also seeing applications of AI, and in particular, more recently, with the advent of large language models, this is where we're seeing their use being really applied. And this is you can, I'm sure there isn't a counter yet, but I'm sure we could create a counter which would just tell us the number of studies that are, have large language model in their title. And I'm sure it look like the US debt right now, because, this is like one of the earlier ones from 2023. It's maybe this one here was just looking at basically using a large language model and saying, I would say the hypothesis was surgeons suck at, communicating the risk, benefits, and alternatives of a procedure. So maybe a large language model would do better. This was kind of supposed to be a non-inferiority thing, but I think their conclusion was more like, yeah, I think large language models do a better job than surgeons do. It kind of hurts, but it's probably true, when you think about it. Other use cases are, this paper was talking about generating education material, especially things like glaucoma, because a lot of these cases, the care provider at home has to really understand what to do. This may affect especially patient populations which are socioeconomically disadvantaged. The average reading level in America, as I understand, is about 8th grade. And how often is it that, maybe when we're talking to the patients, we're using language that's a little bit too difficult, it's too technical. And so the idea here is just like, we're so used to using Google to do things like translate from English to Chinese or English to Korean. Like, just think about this as a translation task. Like, I'm translating from medicalese to, normal person's comprehension level so that they know how to provide the appropriate care at home. So this is another use case for large language models that, again, demonstrated that there's a lot of opportunity here to provide this, especially for our patients here in Flushing with the, not just Chinese, but multiple different ethnic groups. With multilingual models, this is a great opportunity to improve their care. And then, going to the idea of large language models being used, we kind of talked about this in the last talk about how this might be used with training. Before, we've been constrained, right? Because there are interview sessions, and we know that one of the reasons why those are special but also very difficult is just because of time constraints, because it typically requires the expertise of an expert doctor and the time that they really don't have to give to the students to kind of have that back and forth to help train the next generation. So the idea here is, well, what if we could use large language models as sort of a way, maybe not as good as having an expert physician, but maybe good enough that it provides more turnaround and but as we're seeing, it may even be the case that it could actually be better than what we can do in the future. So now, I think there isn't a line here, but I think we can almost draw a line here because here, this is now where we're really talking about affecting patient care in the clinical setting, so decision making. And I would say that really at about this point here, this is where most of this is strictly, this is more in the realm of research and less so in the realm of actual application. Yet, of course, there are cases where it actually is being used, but the last time we actually saw this exact same paper, the Amy paper that Google used and Google presented, and the idea here is that there's a model that was trained on the objective structured clinical exam data. So this is like the OSCEs, the structured encounters that medical students have with typically with actors who act as patients. And using that data, there was a kind of a feedback loop where it would generate a response. There would be a critique model, and it would sort of update the model to try to train it to have better outputs, and it would continue along the cycle. And eventually, their conclusion was it seemed like the outputs were even better than what the actual primary care physicians were putting out. And this is so should we give up? Are all physicians, are we going to just be replaced at this point? Is that it? Is this the end for medicine? I don't think so. I mean, again, one of the biggest issues with all of these studies that show feasibility is the reliance on very clean data. And really data is ultimately the Achilles heels of all these things, because OSCE type data, how many of us write notes that look like that? I don't. I'm going to be the first to say, my notes are probably not looking like that. Our encounters with patients, they're also sparse. There's a lot of ambiguity in what we say and what we write, and sometimes maybe that's on purpose, right? Maybe in some cases, we're trying not to be overly explicit in what we're saying, and this is where yes, these type of models demonstrate the feasibility of it, but real life data is very different from this type of training data. So again, but again, it does show the potential for these systems to integrate with the current care systems that we have. I like to talk about doing, because this is where we're kind of now, up until this point, we've really been talking about sort of that idea from the original definition of AI, like a computer system, like disembodied state, right? Like these are just like computer systems. And here now we're really talking about what about robots? I'm a robotic surgeon. I felt pretty safe thus far, because, you're always like surgery, AI is not going to go there. And then I see some of these studies and, when you get a little bit scared, right? am I next? But it turns out, no, we're still really far. But I think one of the first things that we always have to do when we talk about AI is kind of be a little bit more clear in terms of our classification, in terms of our the language that we use and how we describe things really matters. And so I like this study that was done because they took time to try to see if we can talk about the different levels of autonomy. And because if we have that understanding of what are autonomous systems, then maybe we can work towards them. So they came up with 6 classifications of autonomy. Almost we're basically 99.9% or 99% here. Maybe that's not true because in some cases we are seeing class 1 type of systems, which are maybe we would describe them as like computer assisted or robot assisted systems, in which the operator is still human, but there's something that maybe with like radiology or giving radiation therapy, directing us to where to apply the radiation, or like orthopedic robots to help us have the exact cut. So in some cases, yes, we are at stage 1, but this is about where we're at right now. And from this year point on, from 2 and beyond, this is all really just in the realm of research. And task specific autonomy is something like the surgeon is still doing the case, and it comes to the point of now I don't know why a surgeon would say I'm gonna trust the robot to do the bowel anastomosis, but hypothetically, in this situation, I would say like, okay, I'm tired, robot, take over, do the bowel anastomosis. So that would be sort of the idea with class 2. Class 3 would be something more like what I do currently with my residents. I get up to a certain point, I put in the mesh, they want to close the peritoneum, and I say, okay, I give them control, I'm watching them, but they get to start doing it. And instead of a resident, now it's the robot doing it. So, but I'm still kind of watching and seeing what's happening, or even class 4 is like maybe like a fellow who's just doing a case, and I'm just watching, with bated breath and just like really scared the whole time, but I'm watching, letting them do as much as they want to do. So that's up to 4, but 5 would almost be like instead of fellows, this is some AI system, and 5 is we've seen those movies where someone's in space and they have to have surgery, and the robot does the surgery on them, right? So that's clearly in the realm of science fiction. But this is the kind of classification that they've had thus far. But with this classification scheme, we can kind of ground ourselves in like what level of research, like what are researchers doing? So talking about bowel anastomosis, like this is a study in which these researchers tried to design a autonomous robotic laparoscopic surgical system to do this particular intestinal anastomosis. You can see it's quite a getup, but you can see that there's a robotic system, and without going too deep into it, the idea here is that the robot has to be able to identify and classify that it's got the right end of the bowel. It's then has to be able to take what's on basically a 2-dimensional image and convert that into some kind of 3-dimensional motion, and then appropriately do the procedure. And they show that they were able to do this, albeit in a very controlled environment. But I think what it demonstrates is that these systems, at least what's happening in a lot of the applied healthcare research, they're building upon other systems that became more mature. So, for example, this really required image recognition to be really mature. This would not even get to that point if our image classification algorithms were not working very well. Likewise, robotic technology is advanced tremendously, especially in the last decade. And so, and then, having stereoscopic viewing or, other types of image modalities that are not necessarily RGB images. and being able to synthesize them together. So all of these things work in conjunction, and they all build upon each other to get to these more advanced systems. So great. So these are the use cases. Are we done? No, because there's a lot of challenges. But am I out of time?
Another, maybe, finance.
Okay. So reliability. Reliability is an issue. Automated driving is obviously a case in point for this. We talk about prompt engineering, and this just shows that depending on the prompt, how you interact with the model, you can have as much as 20% difference in accuracy of what that model gives. This one was interesting because this is like, using the multimodal models, having them go in and then giving them a New England Journal of Medicine quiz and saying, can you answer the quiz? And the models did tremendously well. They were like doing just as good as expert physicians to the point where there was no difference between them in a closed book environment. But then when you ask them, well, explain, we saw that like the chain of thought, explain why you got to that answer. Like almost more than 50% of the time or 30% of the time, they gave the wrong reason. They got it right, but they got it for the wrong reason. Sounds just like students and residents and myself, right? So again, a lot of this comes to the fact that if you break down how some of these models do in actual subject matter, there's a huge variation, and a lot of them are doing much better in sort of basic science type of questions, and they do really poorly in the actual application parts. Like cardiology is the worst for these models. So cardiologists don't really. And finally, just to touch upon some of the great discussion we had before, why should we or why shouldn't we be scared that AI is going to take over the world? Healthcare requires a lot of infrastructure, right, to actually deliver good modern healthcare. So does AI. Just recently, this past week, Microsoft said that they were going to have a deal with 3 Mile Island for nuclear power because they need that to power all of their GPUs and their data. Google just signed an agreement with another nuclear power provider because they need nuclear power now to provide all of the power for these data centers. So one of the reasons why I don't think we have to worry is because our brains are very, in terms of the energy they consume and the output they provide, they're very, very efficient. Modern AI systems are very not efficient. Very, very not efficient. So I think that's one of the factors. And lastly, misuse, and we touched upon this as well. I think there's 2 different things that we have to think about. One is misinformation versus disinformation. Misinformation is something that is inherent to every single AI model because fundamentally they're all based on probabilities. So they will always have the ability to give you the wrong answer. That is fundamental to them. And also, if we think about ourselves, we're the same, right? Like, if you ask me a question, there's always a chance I may give you the wrong answer. So we're actually not that different. But misinformation, again, people really kind of hinge upon this because, there was that, they asked the question, what should I put on my pizza? And one model said Elmer's glue. And, this is, it's kind of funny and it just shows some of the limitations, but it wasn't harmful necessarily, but in healthcare, it can be very harmful. But I think we're also worried about disinformation. Now, the difference between the 2 is intent. That disinformation, there is intent to cause harm, or there is an intent to mislead. And this is something that can really only come from humans. Models don't have intent. Humans have intent. So this is where I think we have to be careful that, at least in healthcare, we can have the right intention, and we should do things with the right intention, but we should be wary that we don't, cause harm through misinformation, but we should definitely not be causing disinformation with that in mind. So everything that we've already talked about. So I want to thank you for your time today.
We may have a few minutes for a couple of questions. Of course.
Sorry. I was at a cardiothoracic surgical talk from the model dispute. The funny thing is that do general surgery, right? So actually, they said there's so much innovation that could be processed by AI in terms of approaching certain surgeries, in cardiothoracic, that they came up with new ways of tackling certain aneurysms or dissections and stuff. Do you have that same sort of view of certain GI or some kind of common surgery that you could speed up the time or speed up efficacy or things in the OR to improve your surgical techniques and skills?
Yeah, absolutely. I mean, I think the part that I'm more, I guess, in production with what we've been doing has been more of identifying the appropriate patient populations that maybe aren't getting the services or getting cared for. So we're using, that's what we're using as just even before we get to the operating room, just detecting and making sure that they have the appropriate follow-up. In the operating room, I think the answer is yes and no. It's what I find, at least in healthcare, is that there's always a trade-off because these are systems. So once you add something to the system, if it's not well integrated, you're actually creating more difficulty for people. So I think that's been the biggest difficulty is that we could, I can tell you 1,001 ideas of how to make surgery better. The devil's in the detail. How do I get that to work in such a way that it doesn't add 30 minutes of time, right? Because then who cares, right? I'll do it by hand or maybe over. So it's really that integration part, which is I think the biggest hurdle. And AI, that's the part where AI really has a hard time improving its value.
Great. Actually, believe it or not, we are using AI every day and every time. I'm on call right now as we speak, so I'm actually using AI assisted imaging recognition to detect the large, LVO occlusions or hemorrhages on here, so I can respond to my PE hospital to this, to that, and sharing the session. So we are doing AI every day. I have a couple questions. As surgeons, one of the most challenging moments or difficulties we encounter is complications, right? So these are the typically expected or oftentimes unexpected, and so-called unknown. How do you train the AIs to be able to deal with the complications and unknowns, right? And if a complication happens during the robotic session, will that be relieving your medical legal responsibilities? Or worsening?
So I think number one, medical legal is something that obviously we didn't touch upon directly, but it's always the 800-pound gorilla in the room, right? And I think that one of the issues with AI is that, again, this is my opinion, I think people want someone to blame, people to blame as well. So, the AI system, it's hard, right? And I wonder if that's, when I say blame, I mean because who is accountable in that situation, right? And that's the biggest difficulty is, in some situations, we can trust them. Like, obviously there are products that have been FDA approved, and you're using right now image detection, so it's shown efficacy to the point where yes, even if it misses, the benefits are there. But in terms of complications, I think going back to it, for at least as I am applying AI right now, the biggest difficulty has always been, do we have the correct data to model complications or not? And this is something that is really difficult because most of our data is in unstructured format, it's in text format. This is where I think I like to use AI not for the purpose of predicting or for the purpose of telling me what to do. I like AI for the purpose of cleaning the data so that I have a better. Now, the next step, obviously, from that point on, would be like, okay, if I have sufficiently dense data and I have sufficiently enough of it, then perhaps we can train models to with better better than we can detect when there's a possibility that a complication is going to occur. But we've seen pitfalls with this, like Epic. They have their sepsis model. and it was touted to be very good, and you know, in reality, it's questionable whether it is, just because that's the difficulty with this, because again, the granularity and the goodness of your data is always the main point.
Yeah, certainly AI training is important. We can actually 3D printing models or device, whatever the conditions you are treating with, and train each, frequency complete application to reduce potential application. That's something, in the works actually being tested and worked on. What would, if we reach the stage 5, you mentioned automation. So all you need to do is press a button, it's a surgeon. And of course, who did the discussion, pre-part and, all the other complication, will that relieve your responsibility or relieve your legal, I didn't do the procedure.
I think it'll allow us to go to Mars. I don't know if it'll relieve us of our, accountability. I actually think that what I'm worried about is if we go to that level, we're going to have sort of a 2-level system, because we're going to have sort of concierge or those people who want to have the human touch, or then you're going to have the better models, and maybe the uninsured are the people who are going to be treated. This you can think of 1,001 different dystopian type of futures, but that is one of the that is one of the fears I have, because we kind of see that already in underserved areas, right? Like you kind of get the sense that maybe more things happen there if they have more autonomy to do things. And why would that be different with AI? So I think that's the thing.
Any other questions? Last question. Last question of the day.
It's about surgical training. I'm just wondering, since nowadays, since robotic surgery is so prevalent that if you don't even have one, you cannot even be in the marketplace, right? So in order to train in robotics or whatever, laparoscopically, how do you, because it involves, not hands-on, how do you gain experience and the error prone that, you're gonna make errors as a trainee. So how do you prevent that and also be an experienced, future surgeon, so to speak?
Do you play video games?
This is an area where there's a lot of actually work here in Northwell that we're doing. So the robot systems, they actually are recording all of the motions that you are doing. So per case, you can have hundreds of thousands of data points to that. The hard part there is, how do I reconcile that with the actual inner environment of the patient? And I think that's where we don't have as much sophistication. So this is where if these algorithms did a better job of being able to, through visual models, being able to recreate the 3-dimensional, organs and systems like that. Going back to the idea of like building blocks, building buildings. So if we got to that point, I think then you could have training systems of sufficiently good fidelity that you could actually have, sort of the holy grail of surgical training, which is to have a simulated patient. But we're not really there yet. So it's still me having to give up the concept to the resident. That's where we're at.
Great, thanks so much, Dr. Chung. That's really inspiring. Last but not least, let's welcome our President-elect, Dr. Zhu Zhiqiang, giving us the closing remark before we do the raffle. Don't go away. Twice. That's the end of the day. Go ahead.
Thank you. It is a long day, but I'm sure all the medical knowledge you gained here today, it will help to improve your clinical practice. And